The diagnosis that we would use here, well, we can't really say if it's 911 to 215 because we don't have any documentation for the follow-up, but essentially we need a complete history. We would already have collected all of the medical history, the family history, the social history. That should still be included in your follow-up. Even though you only need 2 of the 3, that should still be included for a full assessment. You're documenting what you're counseling the patient for, you're documenting patient care, and all of the ancillary services that you're providing with as well, and that will provide you with the highest code, 215. And the diagnoses that are written here are the diagnoses that you will use again on follow-up. So, that's all I have to say.
John.
4 visit. 45 minutes have to go by physician or can be your system by myself?
So it's 45 minutes with the physician. That's why I hate time. Time is not a good way to fill out. But it is good to mention it. It's in your documentation, but you should be filling based off this. For an initial patient sleep evaluation, typically 45 minutes is what Medicare wants you to allocate to collect all this data, to do a full physical exam, to do all of your counseling. All of your face time that's spent with the patient is what Medicare is talking about in terms of time.
Even with the system of taking the view system, taking the vital sign, that's
That is your healthcare professional. If it's a nurse that's doing it, that's fine. But again, the way that you would document that is that you reviewed all of the data that the ancillary staff is providing. 45 minutes is what we're talking.
And then for the other case of you present, you give them level 1 because it's not overview system. So it means that the first case,
Yes,
as a doctor, you are doing anything. The patient is going to get all the information for him and he doesn't see that or nothing. Right? Because it's not overview system. What has to do urinary retention or hematuria, the view system, because my coming to me as a pulmonologist to view first thing study.
You got to remember that physicians are the ones who are reading the
So here, the person has to rely to say, okay, I read the hematuria, I do the abdominal exam, a neuro exam, in order to get my level. Because the rest of my time,
Absolutely.
I get on level 1, and I rest all my resources to them see that. And I got paid only level 1. So that's need to be raised also for the
That is right.
That was.
Dr. Allah, it is wonderful that you raised that question. It is very, very important for all of us to know that when we start the patient evaluation and we end the patient evaluation, that is the total timing that Medicare is looking for. They're not looking for you have a medical assistant doing it. So bottom line is that you are absolutely right, that 45 minutes face-to-face with the patients is required. So in my office, what I do is that everything is included based on me, not anybody else. Medical assistant is helping me, but that is included in my EHR, electronic medical record, and the timing starts when the patient gets into the triage. Number 2 question that you have, which is very valid, if the patient comes in, what I'm going to do with the review system? Old days, we used to give a paper to the patient and patient tick mark what is the problem the patient has. And we are supposed to go and review that paper. That was the old system of the review system. Now, in the new system, if you are seeing any Medicare patient, that patients need at least 3 review system which is not included into their present problems list. So if you include that, the 3 system, and in that 3 system you can assess that like the patient do not have, like you were saying, the patient do not have shortness of breathing, sinus, shortness of breathing, patient do not have any, because it has to be review system, the patient has to be asked for, do you have any mouth lesions? Do you have any difficulties when you swallow? Which is not related to the sleep, but review system has to be there documenting other than the present problems. And that is the Medicare guidelines. You are absolutely right, third comment that you made. One time I was giving a lecture in Chicago. Please do not say that outside this room. I know you do. But anyway, in Chicago, I first started giving the lecture and I said, hello, all the liars. All the doctors were sitting there. And one of them said, I'm not a liar. I said, you are the biggest liar. To assess a patient, you are giving ICD-10. ICD-10 is an end diagnosis, not rule in, not rule out. When you have a rule in and rule out, you are critically thinking. But Medicare do not pay you with a rule in and rule out. So you are a solid sure this patient has sleep apnea. Are you? No. But Medicare only will pay you if you put ICD code 10. Remember that. That's why it becomes challenging. What Dr. Singh brought two things. One of them, how to survive. Number two is that we have a disproportionate expectation to the doctor. One is the timing. Number two is that give me the ICD-10 to justify it. This ICD-10 to justify, if you do not, like during this 3 days, we have learned that sometimes sleep apnea may not have any symptoms. Nothing. You understand? But you see a risk factor and you are thinking that is it possible. Now in history, if you don't put that one, you are most likely going to be rejected. So we do bend ourselves. We can write it. Patient is not sure how the patient sleeps at night, though there is a possibility that there is a problem during the sleep because the patient has these risk factors. We twist our pen and write those things, hopefully that we will get it approved. It is kind of a very difficult, but Dr. Majumdar has more experience than me actually in the sleep area. Do you want to comment anything on that, please?
I also just want to make a note too that this is a problem when they track the trends and statistics of which diagnoses are happening. So if we are making a diagnosis without the adequate information, then that diagnosis is now going to be used and it's going to be followed as a demographic. So all of a sudden, we have more obstructive sleep apnea in the last few years than we had before because we're testing for it, we're billing for it, and if that person gets a polysomnography and it comes back and the person doesn't have sleep apnea, that bill was already sent. And the justification, it should be paid. So that when they're doing the diagnostics and statistics for what are the nationwide concerns, we have an inflated level of diagnoses for certain diseases that we have not yet followed up and made the actual diagnosis for. You're absolutely right. You're right. That's the biggest problem with the way that the system works.
Thank you. I think what we're discussing here is very relevant to sleep practice. Many of these sleep studies need prior authorization from the insurance company. And when we assess patient and we say that this patient may have sleep apnea or insomnia or possible narcolepsy, and we order a test, many times insurance company reject that because it's not documented appropriately. And also, given that nowadays some insurance company prefer you to have a home sleep study, and you feel like this patient is better off having a lab sleep study, that is really a good dilemma because many of these insurance companies will reject outright whenever you ask for a lab sleep study. So we face this every day, and in fact, many times I have to call the insurance company for authorization and talk to the physician there or nurse or somebody, I don't know who is there, that go through the checklist and decide to deny or reject the request for a sleep study. So we see that all the time. Now, it is very important to put all those information in your diagnosis, in your history. Give an example. If, say for example, a patient has a CVA, history of CVA and has a memory problem. Now, you ask for a lab study. If you don't put that information, the insurance company will reject that and ask you, why don't you do a home sleep study of that patient? On the other hand, if you put the code CVA or memory problem or dexterity problem, then you can get approval from the patient. If patient has a CHF, say for example, then you should document that in your history so that the insurance company will accept your request for a lab sleep study rather than a home sleep study. So there are a lot of this thing is important to enlist in your history taking and documentation to justify what you're asking for. And also, the same goes with narcolepsy. Give an example, if a young boy came to me, his BMI is 35, he had excessive daytime sleepiness, and all the features suggest that patient may have narcolepsy because his problem started at late teenage, and he has sleep attack, he has hypnagogic sleep and everything. When I requested PhD with MSLT, insurance denied that. Why? Because they said, no, first do a home sleep study to rule out sleep apnea. Yes, patient may have sleep apnea, but then the feature the patient had is more in favor of narcolepsy. So we face this kind of thing all the time in the insurance company. We have to talk to them, we have to document all those things, and then we can argue with them. Because many times, somebody that is sitting on the other end that giving the authorization for the sleep study go to the checklist, and I don't think many of them even understood what they're checking on. And they just go through, if the 10 point is there, then approve it, otherwise we deny it, like that. So we are facing this all the time. That is why I think the documentation is so important before you ask for a particular test. And I agree with Dr. Ahmed that it's very hard for us that we don't have any more rule in and rule out kind of things. So many times, even if you're thinking something in your mind, you have to put something just to get it approved inappropriately. And that, as an ethical fiduciary, sometimes hurts us. We struggle with these things, but we are bound to do this by this so-called insurance company and the CMS criteria that we are saying that here this patient has sleep apnea. Even in our mind, we are thinking possibility of this patient having sleep apnea maybe less than 50%. But just to get the study done, we're saying the patient is sleep apnea. It's unfortunate, but that's the reality, and we have to make sure we document, we put the right diagnosis code so that sleep studies that you want to do, these can be approved by the insurance company. Thank you.
So, thank you very much, but let me tell you is that this discussion can go on and we can be benefited from that, no doubt. Is there any other questions you have so that we can bundle up and answer? No? Okay. Let me tell you about the future of the process of this. In my opinion is that we are having a, I don't know, crisis. When there is a crisis comes in, we kind of move onto that crisis and then we get over and forget about it and crisis resolution. This is what actually is going to happen. Because already in future, that's what I'm saying, already we are in the era where there is a rampant of metabolic syndrome. And it is affecting each and every practice, and then also the children. The problem is multiple. Then when they are going to realize that since 1976 in the United States, heart failure, lung failure, kidney failure, and brain failure at this moment is 10 times more. That's a crisis. That crisis is going to dictate what the hell we are doing. Because at this moment, the allocation for the funds are only to the, I call it 5-star hotel, that means hospital. So hospital-based practice is actually doing everything that they can to patch the problems. But the allocations of the fund is not there in the primary care. Because of that crisis is going to be disproportionately high when they are going to neglect the most important component that we discussed for the last 3 days, the sleep and the sleep, quality of sleep and what sleep can do to our health and our population. Then all this scoring system is going to be changed and modified. You follow me? And that's the saddest part of our life. I think there has to be front visions to identify that. At this moment, we have no solution. We have to do what they tell us. That they justify, we will approve it. So we have to document whatever it is they need to justify that. That is the true fact. Thank you very much, and I appreciate it very much for all of you to come.